Hello again, everyone. This is Dr. Edward Halperin, your host from New York Medical College and Touro University, and welcome back. It's time for COVID webinar number 23, what I think must be the longest running reality viral show on the internet, in which we try to tell you what you need to know for your family, what you need to know for your friends, what you need to know about yourself, and for those of you who are healthcare providers, what you need to know for taking care of your patients about the COVID-19 pandemic and its multiple ramifications. We've got some old friends and some new friends to talk with you about. Those of you who are veteran watchers of these webinars will recognize some people you've seen before, and you'll say, I haven't seen that person before, that's a new one. We've, as usual, snatched our syllabus from the news with the questions that seem to be most pressing for you. We have back with us Dr. Karen Murray, an obstetrician gynecologist. I've asked her to talk with you about the issue of the pandemic and breastfeeding. What do you need to know about breastfeeding if you get COVID while you're breastfeeding, and what do you need to know about getting vaccinated? To talk with us about another ramification of the opiate epidemic, which is going, unfortunately, way up during this pandemic. We've invited back Dr. Ronnie Swift, psychiatrist of the Metropolitan Hospital in East Harlem, who's going to talk with us about the topic. Everyone understands that the number of opiate-related deaths is rising during the pandemic. What are we going to do about it? And speaking about what are we going to do about it, we've got an old friend and a new friend to talk with us about what are we going to do about vaccine hesitancy in minority communities during the pandemic. Dr. Emile Etienne, neurologist and epidemiologist of Good Samaritan Hospital in Rockland County and New York Medical College, is with us with Dr. Shannon Freeman. They're going to describe their research on this topic and what policy recommendations we have. We're going to take another stab at how the pandemic has affected the pharmaceutical industry with our next speaker. I've invited Professor Elizabeth Uni of the Touro School of Pharmacy, and she's going to offer us some thoughts about what the long-term impact will be of the pandemic on the pharmaceutical industry. Then we've got a panel discussion for you. I'm going to moderate a discussion of the public health commissioners of Dutchess County, New York, Rockland County, New York, and Nassau County, New York. Those are Drs. Gelman, Santiago Rosado, and Rupert. And we're going to talk about what the three folks as public health commissioners have learned about being a public health commissioner during the pandemic and what lessons they might offer for others. Then, as usual, you folks will have typed your questions in the question and answer period box on your computer. And during the question and answer period, at the end of all of our presentations, we'll get to as many of your questions as possible and pose them to our speakers. For those of you who want continuing medical education credit for today's program, I will appear later in the program in between some of the speakers and tell you how to get your CME credit, and also tell you about opportunities for financial support of these webinars and for continuing education through our course offerings. So welcome back. Thanks for joining us. And let's get started with our first speaker.
Hi, I'm Karen Murray, Associate Dean for Admissions at New York Medical College's School of Medicine and Assistant Professor in the Department of OB/GYN. Today, we're going to talk about COVID-19 vaccines and booster while breastfeeding. I have no disclosures. The information we're going to see today comes from the CDC, the American College of OB/GYNs, the Society for Maternal Fetal Medicine, and the American Society for Reproductive Medicine. So the topic of the day is, I'm breastfeeding my baby. What do I need to know about timing my vaccines and boosters? And what do I do if I get COVID-19? So we'll start with the first question. In order to answer this question, we'll do a brief review of the information that's currently in the literature. COVID-19 vaccination is recommended for all people ages 6 months and older. This includes people who are breastfeeding, pregnant, trying to get pregnant now or in the future. Vaccination can protect you and your baby from serious health problems that are caused by a COVID-19 infection. People who are pregnant, breastfeeding, should stay up to date with their COVID-19 vaccines, including getting a booster when it's time to get one. So what does the evidence show? It shows that vaccination during pregnancy and lactation is safe and effective. The vaccine does not contain a live virus, so it cannot get you or your baby ill. It is not associated with any fertility problems, either in men or women. The benefits of receiving the COVID-19 vaccine outweigh any potential risk of vaccination during pregnancy and lactation. If you are pregnant or recently pregnant, you are more likely to get very sick from a COVID-19 infection compared to people who are not pregnant. mRNA COVID-19 vaccine reduces the risk of severe illness when infected. Vaccine builds antibodies that can help protect you and your baby. Receiving a booster during pregnancy significantly increases the levels of antibodies found in umbilical cord blood. So with these in mind, ACOG has made a few recommendations. They strongly recommend that lactating women be vaccinated against COVID-19, including getting their booster. Vaccines should not be withheld from patients who are lactating if they otherwise meet criteria for vaccination. A growing body of evidence demonstrates that the theoretical risk of vaccines are outweighed by the potential benefits. Current data demonstrates that lactating women who receive an mRNA COVID-19 vaccine have antibodies in their breast milk, suggesting a potential passive effect to the infant. There is no need to avoid initiation or to discontinue breastfeeding in patients who are receiving a COVID-19 vaccine. These recommendations can also be found at the ACOG website listed here. So let's talk a little bit about booster dosing. The recommended vaccine for booster dosing is a bivalent mRNA vaccine, which can be given to individuals ages 5 and older if you're using a Pfizer vaccine, or 6 and older if you're doing the Moderna vaccine. You can also use an alternate COVID-19 Novavax if your patient is hesitant to receiving an mRNA COVID-19 vaccine. ACOG does recommend that any patient who's pregnant or recently pregnant receive a bivalent mRNA booster dose at least 2 months following their primary dose or their monovalent booster. Vaccinations can occur in any setting. You do not have to defer to a clinical setting. So you can get your vaccination at a mass vaccination site, in a church, or in a school. So some of the key notes are breastfeeding individuals were not included in the vaccine trials. However, the mechanism of action of the COVID-19 vaccine is similar to that of the Tdap, which has been given to in the postpartum period for many, many years. And this suggests that this vaccine is safe. There's no evidence to suggest that this vaccine is harmful to mom or baby while breastfeeding. There's been no severe reaction after vaccination. And reports have shown that mRNA COVID-19 vaccines, when given to breastfeeding moms, have shown up in the antibodies in their breast milk, which could give some kind of passive immunity to their babies. Again, many vaccines have side effects. The COVID-19 vaccine is no different. The most common side effect of the COVID-19 vaccine continues to be pain at the injection site. Here's also a list of some of the other side effects that can occur with the COVID-19 vaccine. The clinical trials that were done in the US did not include breastfeeding women, so the data that I've presented is limited. okay? The safety of vaccines in people who are breastfeeding is still very limited. The effect of vaccines on the breastfed child, as well as the effects on milk production and excretion. The other question that I wanted to answer is, what do I do if I get COVID-19 while I'm breastfeeding? Important to note is it is possible to infect your baby through contact and respiratory droplets. No reports have suggested that COVID-19 is passed from mother to baby through breast milk. Infected mothers may continue to provide their baby with breast milk either while breastfeeding or by pumping milk to be given to the baby by bottle. The caveat is, if you're given to the baby by bottle and there's someone else at home that's COVID negative, it's preferable for that for that person to breastfeed the baby. To bottle feed the baby, I'm sorry. Remember to pay close attention to hand washing and to wear a well-fitting mask when caring for your baby. So let's review. If mom is COVID positive, please wear a well-fitting mask. You can continue to breastfeed your baby in the hope of passing some passive immunity to the baby. Do not cover the baby's face with a mask or any type of cloth. Wash your hands and breast with soap and water before and after breastfeeding your baby. The take-home message is COVID-19 vaccines in people who are breastfeeding has many potential benefits. Stay as informed as you can when you make your decision. Make sure to make this decision with your healthcare provider. We'll continue to learn more about the COVID-19 vaccine we'll continue to learn more about the safety of the COVID-19 vaccine in breastfeeding from studies that are currently underway. Here are my references. And thank you very much for listening.
Hi again, this is your host, Dr. Edward Halprin, with information for the 3 different ways you can go about getting your continuing medical education credit. For those of you seeking credit, you've got 3 choices. Get out that cell phone and send a text message to 828-295-1144. Type in the code 58ACYL, and you'll get a response back by text message telling you how to fill out your satisfaction questionnaire with the program and how to get your CME credit. If you don't like that technique, then go to your favorite internet device and type in www.eeds.com. Click on the sign-in button and put that same code in, 58ACYL, and it'll take you through the satisfaction questionnaire and how to get your credit. Or you can get out that handheld device, and if you know how to do it, scan the QR code and it will automatically take you to the website to get your CME credit and fill out the questionnaire. However you decide to do it, remember, you don't have an unlimited amount of time. Do it between now and 12:30 on Monday, December 12th. Otherwise, the system will expire. And as we continue our presentations, if you have any questions for our panelists, please type them in the Q&A box. Now, every time I do these webinars, somebody sends in a question saying, how do I get my CME credit? So please, folks, take a screenshot, write it down, send a text message right now to get your CME credit, and let's get back to our program.
Substance abuse in New York City post-pandemic. I am Dr. Ronnie Gorman-Swift, and I have no disclosures to report. Substance-related disorders are a problematic pattern of use leading to clinically significant impairment or distress, as manifested by impaired control, social impairment, risky use, tolerance, withdrawal, intoxication, or withdrawal. If we look at these slides, we see that there have been many, many actors and actresses and very famous people who have died from substance abuse. And that just goes to show us how impressive this is. The signs of substance abuse disorder: taking substances in larger amounts or for longer periods than you meant to, wanting to cut down, but you can't, spending a lot of time getting, using, or recovering the substance, cravings and urges, not managing to do what you should be doing, going to work, taking your children to school, continuing to use even when it causes problems in relationships, giving up important social, occupational, recreational activities because of substance use, using substances even when it puts you in danger and you're aware of that, continuing to use even when you know you have physical or psychological problems that could have been caused or made worse by the substance, needing more of the substance to get the same effect. Development of withdrawal symptoms, which can be relieved by taking more of the substance. Identifying a potential drug abuser. First critical step to identifying one is getting a detailed history and psychosocial history. 31% of physicians do not even ask about alcohol or drug use before prescribing opioids. Medical history should always include medications, smoking, alcohol, illicit drug use. Risk factors for prescription opioid misuse include age being less than 45, criminal history, personal and family history of substance use disorder, and mental health problems. 4 common characteristics of patients with drug use disorders is escalating use, the continuous increase in frequency or dose needed to get the same effect, drug-seeking behavior, relentless quest to obtain medication in order to feed the cravings, and doctor shopping, a routine of visiting several doctors complaining of similar symptoms, so to receive multiple prescriptions for the same medication, and scamming, coercion, or manipulation of doctors in order to obtain medications. Identifying a potential drug abuser, a patient who pressures the doctor into writing a prescription after being denied their request, is pathognomonic of a prescription drug use disorder. Though asking for a specific narcotic can be concerning, a doctor must carefully decide whether the patient is drug seeking or pain relief seeking. Patients' requests may actually be based on previous experience where medication was effective for pain treatment. Fentanyl was the most common substance involved in drug overdose deaths for the 3rd consecutive year. It is present in 68% of overdose deaths in 2019. About 51% of all overdose deaths involve multiple central nervous system antidepressants, such as alcohol, benzodiazepines, and opioids. As shown on the graph, the first quarter of 2020 has 96 more intentional drug overdoses than in the first quarter. And we can see by this graph, it continues to increase. COVID-19 and potential implications. Substance abuse disorders, 7.5 million of them had a substance use disorder, and 12,030 of them had COVID. We found that people with substance use disorders are at higher risk for getting and suffering worse effects from COVID. This is especially true in African Americans. Those with an opioid disorder were 2.4 times more likely to have COVID than those without, followed by those with cocaine use, alcohol use, and tobacco use. COVID-19 and substance abuse, preventive strategies. It's important to be aware that certain risks and obstacles a client may go through during and after the pandemic, quarantine and isolation. It's imperative to make sure that the client continues to get support and counseling even after the pandemic is over. Addiction care and counseling must be reinforced and not postponed. Despite measures to prevent the spread of COVID, addiction care must be reinforced and the provider must find ways of still helping the client. Reinforcing addiction care allows for the avoidance of complications that arise from both substance use and COVID-19. It also prevents the transmission of coronavirus by having clients avoid being tempted to go out and use and encounter other people. For healthcare workers, the World Health Organization suggests workers to address false beliefs in clients, such as my body is resistant to the virus, and these drugs protect me from infection. Check in with people who are likely to witness an opioid overdose, such as friends and family, to confirm that they have access to naloxone and know how to give it. Ensure uninterrupted access to medication for treatment through strategies such as giving take-home medications for longer periods and giving extended release formulations. Be aware and vigilant of signs of misuse. For policymakers, strengthen regulations and guidelines to ensure life-saving medical supplies and commodities are available. Strengthen capacity of health social service providers for drug users through short in-service focused prevention and early recognition and management of substance abuse. Train managers and staff about changes in regulations and supply and distribution of medicines during lockdown. Substance abuse and COVID-19, what you need to know. Many people believe that using substances will prevent them from getting COVID-19. There is absolutely no data to support that. So just be clear that that is not reality. Preventing treatment of COVID, there are under no circumstances should someone prevent or treat COVID-19 infection with substances. Dealing with your fear, anxiety, boredom, or social isolation is the route to go. Substance use will not protect you from COVID-19 or help you deal with your emotions and your stress. Save a life. Carry naloxone. Naloxone kits you can get at pharmacies, you can get them through the Department of Health, and you literally can save a life by giving someone naloxone who's unconscious. So let's all do our part and save a life. Thank you.
Hello again, this is your host, Dr. Edward Halpern, hoping some of you will consider giving back to New York Medical College. Programs like you're watching today and our virology research programs take time, effort, and money. We hope you'll consider a tax-deductible gift to help offset our costs. Great things are happening here in New York Medical College. We hope you'll be a part of it. If you'd like to make a gift by phone, dial 914-594-2720. And like we say, operators are standing by to take your credit card information for a charitable donation for our COVID-19 education and research programs, or go online to www.nymc.edu/give to do it all hands-free on the computer without having to talk to a person. And for those of you who believe in ink and pens, we'd be more than happy to receive your check made out to New York Medical College. Put in the memo line on your check, COVID-19 webinar support, and mail it to New York Medical College, Office of Development, 40 Sunshine Cottage Road, Valhalla, New York, 10595. Thanks for thinking of us during these challenging times. Stay safe and healthy. Please consider writing a question for one of our panelists in the Q&A box as the program continues. We'll get to as many as possible. And now let's get back to our program.
Hello, I am Dr. Mil Etienne, Vice Chancellor for Diversity and Inclusion here at New York Medical College. I have here with me the newly minted Dr. Shannon Freeman, who recently successfully defended her doctoral thesis at the NYMC School of Health Science and Practice. Her thesis was on a topic that has been covered numerous times on these COVID-19 webinars, and that is vaccine hesitancy. Dr. Freeman, welcome to the webinar.
Thank you.
We have no disclosures. My first question for you is, what made you decide to study this topic for your doctoral thesis?
So as you know, I work in the hospital, and during the COVID-19 pandemic, what really happened for us here at the hospital is that our entire culture just turned upside down. We had an increase in patients, we had an increase in deaths. And so as the COVID-19 pandemic kind of went along, things really came as a uproar here. And so once the vaccines came out, I would have thought that the employees would have been lining up in the hallways because there was such a big difference in what had happened to our hospital culture. And actually what happened was there was so much hesitancy for our employee population here that we were pulling employees in the hallways to try and make sure that they got vaccinated so that we wouldn't waste the vials of the vaccine. And so I started having these kind of informal conversations with my coworkers and colleagues about why they were hesitant and what really drove their hesitancy. And so there were a lot of different reasons. When we got into the facets of culture and religion, it was really multi-layered and in depth. And so I wanted to go outside of my workplace, and I started talking to my family and friends about it. And I saw that there were similarities in both groups. And so I thought that there was a story there, and it was a story that needed to be told. And so it actually just aligned with when it was time for me to pick a doctoral dissertation topic. And so that's how it all came together.
Okay, yeah, and you had a pretty unique approach to this thesis with both a qualitative and a quantitative analysis. Did you find any differences in hesitancy based on race and ethnicity?
So there were definitely hesitancy variation within race groups. I specifically focused on the African American and Hispanic race groups. And so as you can see on the screen, there was hesitancy throughout the entirety of all the race groups. So when we started looking at African American and Hispanic specifically, there was a great deal of hesitancy, and there was also a percentage of no hesitancy. And so once we started looking at the logistic regression piece of what my primary outcome question was, we found that that hesitancy was not statistically significant for the Black African American group.
And what were the main contributors to that hesitancy when you did find it?
So as we kind of talked about earlier, there was not just one main contributor. There was multiple contributors. There was a multifactorial reasons as to why people were hesitant. If we were looking at the screen here, there are things such as I already had COVID. I wanted to confirm it was safe. I was concerned about the timeline, possible concerns about allergic reactions. And so I think it goes even beyond further than this if we started talking about like culture and religion, as we talked about earlier. So there wasn't one real reason. There were multiple reasons. And I think because COVID-19 vaccines were so new, there wasn't a lot of information at the time. There were obviously causes for concerns. And so another piece of what I found was that for those who had originally said that they were not hesitant, when this question did come up, did they actually select a contributor? So what I found to explain for that was that even though they might have had questions and concerns, it didn't necessarily deter them from getting the vaccines. But as human nature, if anything was new before you go ahead and engage with it, they did have some sort of concerns concerning the COVID-19 vaccines before they got it.
Yeah, again, reminding us that you got to ask each person why they are hesitant. I love the fact that you reached out to the descendants of the men from Tuskegee, Alabama, who were subjects in the U.S. Public Health Service syphilis study. What did you learn from speaking with those family members?
They were great. And, I think what's so interesting about having to make those personal connections with the foundation members, including the president, as you can see here, they were a part of a event that happened in their families that is so widely known. And so for us, we learned about these types of events in our textbooks or by way of our own research. But for them, this was something that happened to their own ancestors. And so it was looked at from them as a different perspective. But when I started talking to them about hesitancy and the vaccines and how they viewed hesitancy and why African Americans may be more hesitant, they were so forthgoing and telling me about why, as an African American people, why we needed to move forward and not look in the past. That's the only way we were going to advance ourselves and really make sure that we were taking all the proactive steps to keep ourselves healthy. So they were actually saying that they want to be first in line when it came out to get the vaccine. And they really want to make sure that they becoming advocates and continue to be, mentors for people to make sure that they make the right decisions, especially for those communities in the African American and Hispanic cultures that are historically more so disadvantaged, historically more hesitant. And so I think their messages really drove home what we really need to see.
Yeah, wow, it's great to hear that they were not hesitant to get the vaccine despite that history. One of those quotes that stuck with me that you mentioned was the impact of generational trauma. Can you share that quote with us and put it in perspective?
Yeah, so this quote is actually from the president of the foundation. And she had said, if there's no reckoning with the cause and the accountability of the trauma, then the trauma does become generational. But I believe with reflections and forgiveness and healing, the trauma can transform with actions, making the situation and the system better for all. And I think that's really powerful because if you think about what we had talked about earlier, they are advocates for the African-American community to become vaccinated. They make sure that they take the steps proactively in the public to make sure that they can see as representation that they are becoming vaccinated, even with that huge event in their family that is so ingrained in African-American history that probably really does contribute to a lot of hesitancy there. But they told us to take a step back, speak healing into existence. And, we talk about how oral history really contributes to hesitancy, but if we speak that into existence in our families and things like that, we can really move forward in a healthy way and really view some of the things that might become or that might be viewed as skeptical in our communities. And we really can just go ahead and make the proactive steps to make sure that we are keeping ourselves healthy.
And to finish off, at the conclusion of your defense, Dr. Kittleson had presented a scenario and said, imagine you find yourself in the elevator with Dr. Fauci, and you have 20 seconds to tell Dr. Fauci something that you think is critical that he be made aware of based on your research findings. What would you say?
So I would definitely need more than 20 seconds. If I could hold the elevator, I would. But if I only had 20 seconds, I would introduce myself and say, my name is Shannon Freeman. Like you, I am a public health advocate. And while I admire the work that you have done, I believe if all of us advocates and government entities work together, our methods for emergency preparedness protocols would be stronger. Public health threats are unpredictable, but to build confidence in the eyes of the public, we should be united and not divided in our message to keep all communities safe.
Well said, Dr. Freeman. Thank you so much for those clear responses and congratulations on this wonderful dissertation.
Thank
I am
you.
sure our audience will have many questions for you.
Thank you, and it was a pleasure to participate.
Good afternoon, everyone. Thank you for joining today for the symposium. My name is Elizabeth Uni. I'm an associate professor with the Touro College of Pharmacy in New York. I also chair the Department of Social, Behavioral, and Administrative Sciences. My topic for the day is the long-term impact of the COVID-19 pandemic on pharmaceutical industry. I have no conflicts of interest to declare. The COVID-19 pandemic touched everyone and everything and created ripple effects, and pharmaceutical industry was no exception. In the next few minutes, I want to focus on the top 4 effects of the pandemic on pharmaceutical industry. The first and foremost, in my mind, is the way there was a shift in the design of clinical trials. As you all know, the clinical trials were always centralized and happened within the huge healthcare systems. With the pandemic restrictions, this had to change. We couldn't bring patients to hospitals. So we went to the patients and the trials became decentralized. Several smaller hospitals and clinics in the community became part of the clinical trials. This surely was a blessing in disguise as it increased the diversity of study participants and community engagement. There was also an increase in the participant recruitment and retention as the trials were happening in the local communities. In addition, we were also able to collect more real-world data as these study participants were slightly different from the participants we usually had for the centralized trials. These were the patients who might probably be having other chronic disease conditions. So in short, we may end up having more clinical trial hubs around the country for participant recruitment. and industry may also use more digital health technologies for data collection. So this was one of the impact of the pandemic on the pharmaceutical industry. Another long-term impact is a collaboration that has happened with pharmaceutical industry. A classic example for this is the recovery trial. As can be seen from the screen, this is an international clinical trial to identify treatments for COVID-19. As can be seen from their webpage, the study is happening across 6 countries with around 200 sites and close to 50,000 participants from around the world. This means that we had to develop a standard clinical protocol that is being used across all these 6 countries. So this is a huge shift in the way we have always done clinical trials. A second effect of collaboration is the intentional effort to bring medicines to patients faster. We witnessed this with the vaccine development, and now companies are taking steps to make this a standard. They have found ways in which small groups are formed who are accountable for their work, and they collaborate better between teams. Another example is a collaboration between industry and FDA. The industry had to develop ways in which to work with FDA for their inspections when work was remote. So they developed what is known as alternative FDA inspections. And though all of these things may not stay, some of these remote inspections are going to stay, which will make the work more efficient and effective. A third impact is the form of communication from the industry. Industry always had the opportunity to visit the physicians and payers directly face to face to educate them about their products, their pipeline, and their needs. All these visits became remote during the pandemic, and the industry still had to meet with the payers and providers and meet their demands about the products. And even after the pandemic, or after the effects went down, with the travel budget restrictions and hesitancy among participants who travel, there's a change in the way the pharmacy industry is communicating with payers and providers. One thing they have done is to develop relationship with providers and payers early in the drug development process, which is really good because we are actually meeting the demands of these people during the drug development process itself. Also, there is more publications and white papers from the pharmaceutical industry, and there's an increased presence of industry in the social media. Also, there's an increased data transparency from the industry because products are being formed faster, and they need to let the payers and providers know what data is existing behind this. The last impact from the industry due to the pandemic is their increased commitment. During the pandemic, the image of the industry improved a lot. The population realized the presence of scientists and a lot of other people working in the industry for the common public health good. And we also know that the infectious diseases and the infectious diseases can have a huge impact on the population for their health as well as economy. And so there's a bigger commitment to invest in products that can be used for infectious diseases and immunology. There's also a commitment or an increased commitment to self-sustainability. We had cases of drug shortage due to dependence on other countries, either for the raw materials or for the products. So we're trying to develop ways in which we can be more sustainable. A third one is a commitment to innovations. As we already discussed, the industry has made ways to use, for example, digital health technologies to be a part of clinical trials for data collection. Or they have found better ways or innovative ways to develop working relationships between different companies or between different countries. So in general, there's a higher and improved commitment to innovation. So these are the four effects, or the major effects the pandemic had on the pharmaceutical industry. Thank you so much for listening.
Hi again, this is your host, Dr. Edward Halprin, with information for the 3 different ways you can go about getting your continuing medical education credit. For those of you seeking credit, you've got 3 choices. Get out that cell phone and send a text message to 828-295-1144. Type in the code 58ACYL, and you'll get a response back by text message telling you how to fill out your satisfaction questionnaire with the program and how to get your CME credit. If you don't like that technique, then go to your favorite internet device and type in www.eeds.com, click on the sign-in button and put that same code in, 58ACYL, and it'll take you through the satisfaction questionnaire and how to get your credit. Or you can get out that handheld device, and if you know how to do it, scan the QR code and it will automatically take you to the website to get your CME credit and fill out the questionnaire. However you decide to do it, remember, you don't have an unlimited amount of time. Do it between now and 12:30 on Monday, December 12th. Otherwise, the system will expire. And as we continue our presentations, if you have any questions for our panelists, please type them in the Q&A box. Now, every time I do these webinars, somebody sends in a question saying, how do I get my CME credit? So please, folks, take a screenshot, write it down, send a text message right now to get your CME credit, and let's get back to our program. Hello again, this is your host, Dr. Edward Halprin, and I'm going to serve as your moderator for a panel discussion with 3 county public health commissioners who are going to chat with us about what they've learned about being a public health commissioner during the pandemic. We have with us the health commissioners of Nassau County, New York, Dutchess County, New York, and Rockland County in New York. Doctors Gelman, Santiago Rosado, and Rupert. I'm going to pose several questions to our guests, and we're going to hear from each of them with their responses. As always, as you listen to my questions and their responses, if you have questions for any of our public health commissioners, type it in the question and answer box on your computer, and we'll get to as many of them as we can during the question and answer period. The first question I'd like to raise for our 3 guests is to talk about the spectrum of overriding principles versus local conditions. There are some people who say that all politics are local. There are some people who say there are overriding principles which transcend local conditions. In the case of your county, how was your management of the pandemic in your county based on general principles, and how much was based on particular and peculiar local conditions or local populations? And what were they, and how did you deal with them?
This is Dr. Patricia Schnabel-Rupert, the Commissioner of Health of Rockland County, New York. With the communities that we have in Rockland, including our ultra-Orthodox community, we need to focus and have focused in the past on, especially during our measles outbreak and certainly with COVID, we have had to focus on the specific ways to communicate with various populations in our community. Not everyone utilizes social media. Not everyone is on computers. So we have to utilize other educational means in order to reach the population. Also utilizing community liaisons when possible. That's what we did, of course, during measles and continue to do during the COVID pandemic.
Dr. Irina Gelman, Health Commissioner, Nassau County. Thank you for that question. I believe that, of course, there are fundamental principles of public health that must be adhered to, regardless of the situation at hand. However, local principles do take over, and some of the dynamics are absolutely a part of the consideration. And especially New York State, being a home rule state, it's very important to consider the specific dynamics within counties, because clearly counties that are more rural, that are further away from New York City, have entirely different considerations, whether it's pandemic response or other issues pertaining to public health. And it's very important to integrate both.
I'm Dr. Olivia Santiago Rosado. I am the health commissioner in Dutchess County. And actually, thank you for this question, because it's actually an interesting question in my case. I actually was not the health commissioner for the bulk of the pandemic. I came into my position in December of 2021, right as Omicron was getting started. Prior to that, I was the chair of emergency medicine and running the emergency department at a hospital in my county. So I was seeing the pandemic from a very different perspective. But I think the question applies to sort of both the positions that I held throughout this pandemic. I think the answer is kind of the same. So I would say that for the most part, a lot of the management of the pandemic was really based on general principles. And the reason for that is that, when we think about the time before Omicron, when I was in the emergency department, I was actually really benefiting from the fact that I had a lot of connections in New York City. I worked in New York City for almost, 20 years in emergency departments between the city and Long Island. And so I was able to sort of see, it was almost like watching the tidal wave come in, with the benefit of having about 8 to 10 days lag time behind what was happening in the city. And so rather than reinventing the wheel, I was really learning from my former colleagues what they were seeing, what the character of the people that were presenting were, and what they were doing about it, what their hospitals were doing about it, what the healthcare system as a whole was what the response was and what was working and what wasn't. Once I started in this position, December of 2021, I kind of applied the same principles of seeing what was happening in the counties and the areas that were hit a little bit before us, trying to get as much information and as much wisdom from those interventions that were being implemented elsewhere, and really, kind of learning from that. I would say though that, even though the general principles, those overriding principles do supersede the local conditions, that doesn't mean that paying attention to local trends isn't important. So it's a little bit of both, but I think generally I would say that it was more the overarching principles that I was following.
Our next question will call for a bit of self-reflection. I'd like to ask each of our commissioners if they gave you a do-over, what they call in golf a mulligan, a do-over regarding one management decision you made as a public health commissioner during the pandemic, what would it be? What decision do you wish you could retract?
I think we will back up a little from that question. And if I had one wish, sort of say, and a do-over, I would start pre-pandemic. And I would advocate a lot more vocally on behalf of public health and resources and funding for public health, because the one rate limiting factor that we've all experienced throughout the duration of public health, whether nationwide, statewide, locally, was really the lack of resources and funding that was in place for public health prior to the pandemic. And we have all felt that play out throughout the duration of the pandemic response. So if there was a do-over, I would absolutely advocate more vigorously and vocally on behalf of public health to receive more funding and more resources and more staffing, so we'll be better prepared to handle what we were absolutely dealing with on a daily basis.
Thank you for that question. I don't have any, I would not make any changes in what I myself have determined or decided.
Perhaps, I guess, it's only been a year, and so I don't have a lot of quote unquote do-over moments. I would say there was one early on in Omicron, right? I was, again, just sort of noticing what had been happening, how this wave, very, severe in terms of the number of people affected, the transmissibility of this particular variant, how it was sort of moving through first Africa, Europe, et cetera. And so looking at that, I thought it was really, really important to get home tests. I knew that they were expensive, that they were kind of hard to come by, and if you just went to the store at that time to try to get one. And so I had, lobbied the county to go out and procure a bunch of home tests to be purchased and to be available to our community. We actually were able to move so quickly that we actually did get a bunch of tests when it was almost very quickly after that, it became almost impossible to get them. But it would turn out that about 2 to 3 weeks later, the state did purchase a large order and then started sending it to the county. So had we just kind of sat on it a little bit longer, we might have been able to save some money. But frankly, I still don't really know that I would do it over. I'm glad that we were definitely out front with it. There were a few other things though that happened again before my taking this position as a health commissioner, in terms of what was happening in the emergency departments. And, I think I didn't really have a hand in these decisions, but I think a lot of decisions were made during the early part of the pandemic, as far as healthcare systems are concerned, to, in the early part of the pandemic, there was a, what you could call a paradoxical drop in volume and volume of people coming into the ER, and therefore coming into the hospital. We were in lockdown. A lot of people were afraid if they showed up in the ER, they would catch COVID from somebody else who might have been sick and was being treated there. And so what we actually saw was a decrease in the number of patients generally that were coming in. And I think a lot of health systems, because they had this decrease in volume and decrease in volume of surgeries and a lot of other, elective surgeries and things like that, that really are the bread and butter of health systems. A lot of health systems did make decisions to downsize their workforces in response to that. The problem was that really was a temporary thing. And so those patients came back pretty quickly, after about 4 or 5 months. And unfortunately, because those workforces had been downsized, the ability to respond to those patients coming back in was probably an issue. So there were some things I think that happened throughout the pandemic that we probably need to look at in terms of the wisdom of some of those decisions, but not necessarily in my role as a health commissioner, but perhaps some decisions that were made prior to that. Where had I been, in charge of those decisions at the time, I can't say that I wouldn't have made the same decisions, but certainly in retrospect, again, even though I wasn't part of those decisions, I do see that that's an area of opportunity for improvement.
Our final question for all three of you involves the management of elected officials. I'm sure that all of us have witnessed a variety of strategies of elected leaders interacting with public health commissioners during the pandemic. New Yorker saw Governor Cuomo doing almost all of the talking during his press events, while his health commissioner remained relatively quiet. In contrast, Governor Inslee of the state of Washington and Governor Cooper in the state of North Carolina would greet the audience and then turn the program over to their state public health commissioners to do most of the talking. If you were called upon to give advice to an elected official as to how to work with their health commissioner during the pandemic, what advice would you give about the best way to differentiate the work of the elected official versus the work of the public health commissioner in giving the public advice?
Thank you for that question. Politics should not interfere with public health decisions. There should be respect for what the public health authorities have to say, and politicians, though elected by their constituents, should relegate that authority to the public health officials and not interfere.
I think it's a combination of both, really. Again, it is a dynamic where you do have an elected official, which essentially is the choice and the voice of and for the people. So it's very important to have that instrumental part of communication. So if the public is more receptive to receiving information from their elected official, by all means, that communication may go and be received from that public official. And the expertise, I think the crux of that question lays in the area of expertise, whether that's public health or otherwise. It is important to rely on your subject matter experts for the expertise and the advice, and really to chart the direction and the course of the pandemic response. So when you are dealing with a communicable disease pandemic, it is important to rely on the subject matter experts. If nothing else, if not so much for the communication aspect and communicating the message to the public, but in the least for the information and reliable source of direction for the pandemic response. I think it is really a matter of having that fine line of having both.
I think during the first few months of lockdown, there was so much confusion, and the communication from the federal government seemed to be disjointed and come kind of sporadically, right? There wasn't a cadence to the communication. So I was actually very appreciative of the communication from New York State because of this vacuum that had been sort of left. And I say that having been, an administrator, healthcare administrator and emergency department leader through, for example, the H1N1 pandemic in 2009, which was handled very differently. There was a lot of communication coming from the federal government, and underneath that, then there was a lot of uniformity and standardization in terms of the communication and the actions that were being taken at the state level and the local level. So this was different in that, again, from the federal government, there really wasn't a lot of structure. So those daily updates, which had an established and aggressive cadence that they would come almost daily, I think they did bring some stability and were a source of confidence in terms of knowing what was going on. But the problem is that, when you have Governor Cuomo, who was a controversial figure and remains a controversial figure to some extent, I think sometimes the messenger can sort of take away from the contents of the message. And so because he already sort of had controversy around him, and some people may have had different opinions of him preceding all of this, that sort of colors the ability of people to listen to that message. I think that having the politician be the voice, whether it's President Trump or Governor Cuomo, kind of ended up being bad for public health as a whole. So you ask, is the alternative then to have the health commissioner be the primary communicator? And to that, I would say maybe, but it kind of depends on a health commissioner, and it depends on you know, are they media trained? You know, can they really explain things in a way that is, you know, appropriate for a lay person audience? Do they use technical language that's going to get people lost or intimidated or confused? I think, you know, certain people are better than others at being sort of the communicator. Even though they may have expertise in public health and in healthcare, their ability to communicate that may not be there. So what I would say is that my suggestion would actually be that the primary communicator should be someone whose expertise is communication. So I'm thinking kind of like the president has a press secretary or something like that. So it should be somebody who is able to convey complex information and simplify it for a lay public. But also it should be someone who is able to sort of do it with subtlety and not necessarily sort of tie into that politician, which may turn off a segment of the audience against the content of the message. And then if there's a Q&A, you know, say, for example, you had a press conference, you could have this communications person be the primary communicator. And then as questions come up that are more specific and more amenable to, say, a health commissioner or perhaps even the governor to answer, then they would become involved as the subject matter expert. But I think, you know, again, one important lesson that we have learned, or we should have learned from this pandemic, is that communication is incredibly crucial. How we communicate those messages and who the communicator is becomes incredibly important when we're trying to make sure that the population is aware of risks, for example, aware of what we want them to do, aware of why we want them to do certain things, without turning off a significant proportion of them just by virtue of who's doing that communicating. So again, this has been wonderful. Thank you so much for all these questions, and I appreciate it. Thanks.
Hello again, this is your host, Dr. Edward Halpern. I'd like to offer you a thought for those of you who are fired up with interest in public health based on these webinars or on some of the medical ethics questions we grapple with. If you're interested in some coursework or even a master's degree in public health, go to nymc.edu/COVIDPH, and you can learn all about our course offerings, certificate programs, and degree programs in these disciplines. For those of you interested in medical ethics, nymc.edu/COVIDethics for our full range of courses available online and in person about medical ethics. Perhaps you have a family member or a child interested in these disciplines, and everyone's welcome. Well, we hope you've enjoyed our panel presentations today, and now it's time for our question and answer period with our moderator, Dr. Alan Kadish. Dr. Kadish, the floor is yours.
Thank you so much, Dr. Halpern. We actually had a lot of questions for the panel today. So without much more by way of introduction, I'll go ahead and begin. First question is for Shannon Freeman and Mille Etienne. Someone said that they'd read about church auxiliary groups and barbershops being used to involve people in minority communities in mammograms or high blood pressure screening. What do you think about using that for vaccine hesitancy?
Yeah, I can start. Yeah, that's an actually really great approach. I would say this is what we call using the trusted agents in the community. People who when people go to get their haircut, they trust their barber. If their barber is saying, hey, you should get the vaccine, a lot of times people will be convinced. In fact, I told my barber to make sure he tells everybody who sits in his chair to get the vaccine. But it's a very good approach because a lot of times we know with vaccine hesitancy, one of the main concerns is trust. So having those trusted agents is a great way to go about that. Thank you for that question.
Sure. The second question, again, for the two of you is, what did you learn you think that we should do better in the next pandemic, which of course we hope won't happen, but probably will?
Dr.
Do you
Freeman?
want to start, Dr. Ed? Do you want to start? It's a good question. So just looking at my own research and then research that's already out there, it's one of the things that I talked about in my dissertation is that we really need to go ahead and look at those emergency protocols that we have now, looking at all the things that happened for COVID-19 that didn't work and all the things that really need to be fine-tuned across the board for all federal entities working its way down to the local levels. And so I think it's really looking at where we went wrong, what were our holes, and then moving forward, just building plans to make sure that these types of things don't happen.
Thank you. Mill, did you have anything you wanted to add?
Yeah, and I just wanted to pivot back to what Dr. Freeman had said in her 20-second pitch to Fauci, which is the importance of that united front, the various entities that are all trying to combat this pandemic need to get together. And really, probably, I would say the most important thing about planning for the next pandemic is that we have to start now gaining the trust of all those communities. Because once the pandemic starts, you're way behind the curve. So this is the time now to actually gain that trust. Thank you for that question.
So the next question for the two of you is not just related to the research that you presented, but is a more general question following up on what you just said, Dr. Etienne, which is the U.S. system with county, state, federal public health departments, spokesmen from the NIH, CDC, and FDA, is it just too decentralized for the question relates to united messaging, but I would expand that to united action against a pandemic. Do we need something more radical in terms of changing the way the public health system is organized in the United States? And would that help in underrepresented minority communities?
Dr. Freeman, you want me to go or you want to go?
Yeah, you can start.
Yeah, so I think like many different challenges in medicine and healthcare, the two-pronged approach is essential. We absolutely need that central response from the federal government. They provided the vaccines, they provided a lot of the guidance, but we also need those local folks who actually know their communities a lot better. Each state has different challenges, and even within the states, each county, each village, each hamlet, whatever, or what have you, they have very different challenges. So we really do need those local folks to be able to weigh in on what's going to work and what won't work in those communities.
Yeah, and to piggyback off of what Dr. Etienne said, I would agree. Working as a community health coordinator here and participating in our community health needs assessment, working with all different community organizations, the local level is so important because no one knows the people that they serve better than they do. They work with them on a daily basis. And so if we are able to craft plans locally based off of the information that's given from the state, I think we are able, to put boots on the ground, making sure that the people that really need to be involved are involved.
Okay, thank you. One more question, then we'll let the two of you rest for a bit. Have you identified people or groups that you think have been effective at overcoming vaccine hesitancy in minority communities? And conversely, are there people or groups, not necessarily individual names, but just sort of more generally groups that have been a barrier to widespread use of the vaccine?
Yeah, I'll comment briefly. I'll say the barrier, one of the big barriers was social media. And unfortunately, it seems like the folks who were anti-vaccine had a much better strategy when it came to social media to get people to be hesitant, to keep them from getting the vaccine. So I think that's another thing you could do better the next time around is really mounting up a much better social media campaign and really targeting people based on people who they'll respond to. I know in Westchester County, for example, when the vaccine got approved for children, we had teenagers go and speak to the community on webinars like this, so that the students could hear from people like them who they actually trust. And then that's I'll stop there. So Dr. Freeman has a chance also.
So, piggybacking off of what Dr. Etienne said, even in my own research, social media was a huge contributor to vaccine hesitancy. There was so much misinformation, I think, that was put out there on social media that was just written by, many different people. And I think when we're starting to talk about how we can increase that vaccine hesitancy, we're looking at people in the communities that these communities look up to, so religious leaders, community leaders, people that they go to for guidance and information all of the time. Representation is big. I think that's another thing that we played on when we started looking at the African American and Hispanic community, making sure that we're getting leaders, community leaders that look like the people that they are trying to get vaccinated. There's a certain type of trust in that too, when we start looking at things culturally and religiously too. So I think it's really making sure that those people who are involved in their communities really make sure that they go out and put that message out there, someone that they can relate to.
Great. All right. Last question is actually for Dr. Etienne, for you as a neurologist. We've talked about this at some prior sessions, but there are some data about one of the side effects of COVID-19 vaccines being hypercoagulability and blood clots. Is this real? How much of a problem is it? And should people be concerned about it?
Yeah, early on in the pandemic, one of the vaccines did have some cases of sinus thrombosis, which is a clot in the brain. It is an issue, but it's not something that's that common. It's fairly rare. So that would not be a reason to not get the vaccine. I would say that the benefits of the vaccine far outweigh the risks of actually getting one of these clots. They're exceedingly rare.
That's great. Thank you. So we'll let the two of you rest, and we have a couple of questions for Dr. Murray. First question is a quick one. Is it dangerous to breastfeed if you're taking Paxlovid? Do we know, and what would you recommend people doing?
Hello, Dr. Kadish. Yeah, if you are breastfeeding, the recommendation for Paxlovid is to not to breastfeed. So if you're currently breastfeeding, you're going to pump and dump for the duration of the medication, and continue up till about 7 days post your last dose. So while you're taking Paxlovid, and for 7 days after Paxlovid, pump and dump, and then resume breastfeeding after the 7th day.
Great. Second question is, do you know of any data about how the pandemic affected the prevalence of breastfeeding? Did you might think people being at home, shortages of formula actually increased the incidence of breastfeeding? Do you know if that happened, and what do you think the implications of that are?
Well, actually, the opposite happened, believe it or not. So the prevalence of breastfeeding actually went down. They started looking at breastfeeding in 2019, which is right at the start of the pandemic. And they're currently looking at 2020 and 2021 right now. And it seems like in terms of when they say breastfeeding, they're talking about exclusively breastfeeding for up till 6 months. And in terms of the initiation, many people initiate breastfeeding. So in the very beginning, right out of the hospital, most people will breastfeed. About 80% of people breastfeed. When they start checking it about 4 weeks later, it drops down to about 70%. And then it drops down to even further than that, into the 40s. During the pandemic, exclusive breastfeeding dropped. When they looked at it in around the 6-month time period, it dropped down from like about 42% to about 28%. And the theories behind that is, even though people are off, they found that the fact that they didn't have the availability of the WIC personnel to do like in-person breast teaching and breastfeeding and running the gamut in terms of like problem solving, that many people got frustrated and did not continue breastfeeding. There's also some types of socioeconomic differences where, people who were low income tended to breastfeed less, which you would think is counterproductive. But that's because breastfeeding is actually pretty expensive. When you go back to work, you have to, you have to take time out of your job where you don't get paid to do these pump breaks, but you also have to buy the equipment such as like breast milk storage and figuring out how to store the breast milk and stuff like that, which can become kind of pricey. So the folks who've had to go back to work and didn't have the luxury of working from home, which again is more so of your lower socioeconomic personnel, the breastfeeding tended to have fallen off. So overall, the number actually did go down.
Okay, thank you very much for that.
Thank you for the question, Dr. Kadish.
Next series of questions is for Dr. Swift. The first one is it possible that the pendulum has swung too far on the opiate issue? Physicians seem reluctant to even prescribe post-operative pain medication because of increased regulatory factors and concerns about overuse. So do you think we're at a good place currently in opioid use, or is it perhaps too restrictive?
I don't think it's too restrictive. I think we had gotten very casual about prescribing and trying to make sure the patient had enough medication so they didn't call the doc right away or the dentist or whoever. And I think what all these things put into place was some safeguards, because we do know that there are definitely people who are more predisposed to substance abuse in general, and certainly opioids. And so now there's a lot less likelihood that somebody is going to become addicted to opioids because of something a doctor or a dentist gave them. And actually, dentists were the ones who had the highest rate of getting younger people started on opioids, post having molars out and things like that. So I think we just have to be really, really cautious. And if you truly have pain, these are wonderful drugs, and they make a real difference in people's lives if they're used appropriately. So I think we just have to dial back a little bit, as we have done, and try to identify people who are at risk for abuse and not disadvantage people who genuinely need these drugs.
Sure. So let me ask you. No, I think that's a very good answer, and certainly I would agree with it in general. Do you prescribe opioids ever?
No, I do not.
Okay, so what I can tell you from people who take care of patients who might need opioids is that most of the colleagues I deal with actually will never prescribe opioids because of the combination of concern and regulation. And so we'll see how that sorts itself out over the future. So the next question is, there's been a lot in the press about lawsuits and settlements directed against opioid manufacturers. There have been fines, but so far no one has gone to jail. Is that effective? Or do you really think, I guess the subtext of that question is, do you really think that there's criminal actions need to be undertaken against individuals to make this really, sure this is not going to happen again?
I think certainly there may be some value to that, but I choose to focus on the fact that there is going to be a lot of money for education, for preventing this from ever happening again. I think the pharmaceutical companies may have had some sense of what was going to happen, but I don't think they're the only part that's responsible. So I think a lot of we can use this money to do good, to do education, to improve people's lives, to change their lives, to change the whole equation of substance abuse and turn it into people using medications appropriately and telling them when enough is enough, and not making it convenient for the prescriber, but rather what's appropriate for the patient.
Okay, so I can't resist asking a follow-up question based on what you said. You said you don't think the pharmaceutical companies are alone responsible. So what other factors do you think were responsible for the overuse of opioids?
I think there was really a lot of misinformation out there about what is and is not effective. And don't forget, there was also at that same time, there were a number of regulatory agencies that were coming out and saying, ask every patient at every visit, do you have pain? Well, when we started doing that, unfortunately, a lot of people began to use these drugs in a way that was not appropriate for them. And so we society partly created this. Believe me, I don't let the pharmaceutical companies off the hook at all. I think they knew a lot of what was going on. But I also think this idea of asking every patient at every visit, do you have pain? And then going on something very subjective. People who were abusers started coming in and asking for pain meds at every single visit. And that's why we now can check, did you get medication from somebody else that's the same medication as another physician is prescribing? And also, do you really need, after a procedure, how long do you really need to be medicated for? Do you really need a 30-day supply? So I think there are a lot of factors involved in this. And I would just like to focus on how can we use this money and do something good for society and the people who have thus far been disenfranchised by this.
That's a great point. So last question for Dr. Swift. As a psychiatrist, perhaps you could weigh in on something Dr. Freeman said, that we have a generational psychic trauma. What do you think we needed to do to help people with that? What strategies are there?
I think we have to acknowledge history is history. And every part of society has been affected by one thing or another. But we can't carry that on forever. We have to get beyond it and say, what are we going to do as a group of people that's living now, that are living together, that are trying to make a life for ourselves and our children and our children's children? What do we do to make the world a better place? And how we can't go back. We can only go forward. And I would like to emphasize that to the extent that we know these horrible, horrible things happen. Tuskegee, there's no excuse for what happened there. We all know that. And we would hope it would never, never happen again. But if you look at history, there have been things comparable, maybe not to the same extent, for almost every ethnic and religious group. And so we have to let go of some of this and try to make a better world together for all of us to go forward. Thank you for that question.
Thanks so much. That's a great way to end your questions.
Thank you.
Last, Dr. Uni, we have several questions for you. Since you presented first, I saved you for last. So the first question is, do you think that the COVID-19 vaccines that were available in the United States were unnecessarily restricted? That is, other vaccines are available in other countries. Do you think we should have been more lax in the vaccines that are approved so we had more vaccines available? What's your thought about that?
Sure. So as we all know that this is something that came so unpredictably and we were not prepared for something like this. So in a situation like that, when there is a public crisis, public health crisis, I think the US government and the FDA was very careful and very cautious about what they were approving. So yes, there were vaccines being manufactured in other countries, but we were not at a place and time to approve all those fast enough. Or many times the manufacturers in other countries did not even submit an application with the US FDA to see whether they would like to have the drug approved. One example for that is the drug that was manufactured by AstraZeneca in India. Very recently, in the beginning of this year, only they even submitted the application to the US FDA to see whether it can be approved here. And now they have an approval from the FDA to do the clinical trials in the US population to see how that will happen. So I don't think we shouldn't be lax in a situation when there is a public health crisis. And I think our agency was very cautious about what they did. And I don't think we have been disadvantaged in any way
with that. Because also if you look up at the number of vaccines that has been distributed across different countries, we were just behind Canada in the number of vaccines as a country we received. So I don't think we had been at a disadvantage in any way. But thanks so much for that question.
That's great. Thank you. And of course, some of the vaccines that were approved in other countries turned out not to really work. So that's the danger of, as you point out, of regulation that's too lax. You indicated that visits from industry representatives to physicians decreased during the pandemic. Is that good or bad? What do you think about drug detail visits? Now that they don't bring gifts anymore, is it
Right.
good or bad?
So, the one thing that we have to remember is that, there is a pretty bad image the pharma industries are carrying around. But as you can also see during this COVID crisis, they were so fast and they worked with us. And there's a lot of scientists and physicians and pharmacists working in the industry. It's not just the business suite people. There's a lot of science also going on there. So when they visit the physicians and the payers, it is not only the drug reps coming and talking about the drugs, but there's also a lot of education that is going on there too, because this is the one place physicians actually get to know about the prescribing guidelines, about the medicines, the formulary part of it. All those things are happening during this time. But this is also a time for the industry also to ask these physicians and payers what they would like, right? Which way we should go, what should their pipeline be, what are the things they are looking for. So it is actually a two-way conversation that happens during those visits. It's not just the drug representatives, it is also a lot of medical science liaisons who are pharmacists or nurses visiting these physicians and talking to them. So yes, the kind of communication has changed, but I don't think the quantity will decrease because they still have to communicate with them. So maybe the type of communication changed, but I think the quantity is still the same. And as you rightly said, there's a lot of regulations on what can they do and what can they talk during this conversation. They cannot bring any gifts, they cannot do certain things. So it is a highly regulated visit compared to any other visit actually that is happening. So again, we need to trust our agencies as to how cautious they are in having these policies and regulations in place to protect us, the public. And thanks for that question.
Sure. Thank you. Last question. You talked about the dependence on other countries for raw materials to make vaccines and drugs, and perhaps in some cases, manufacturing capacity. Do you think we need a change in national policy to be sure that those materials are available and that we have adequate domestic production?
Yes, this has been a concern even before the COVID, and I think the Center for Drug Evaluation and Research, which is under the FDA, had been working to see what can be done to increase the production of raw materials in the US. But it is not purely a science, it is also a matter of economy. Where the pharma companies are getting the raw materials from depends on the price of the raw materials also. So I don't think we, as a capitalistic market, can tell our pharma companies where to get their raw materials from, but there's a lot of discussions and strategy placements going on with the pharma companies to see how we can increase the production of these raw materials within the US so that we will not have these kind of issues happening. So this conversation started even before COVID, and the COVID only accelerated these discussions, and hopefully we'll have more strategies in place so that we do not have these kind of issues in the future.
One last question. How would you rate the performance of the pharma companies during the COVID pandemic?
Well, I would say they did a pretty good job, because, as I rightly said, there is a lot of times they take a lot of rap. And this was a time we saw that many of our scientists, they were working so hard to make these things happen. And the pharma companies had been working very closely with the government agencies, like, for example, when the remote inspections had to happen, making sure that all these things are happening and none of the approvals are being delayed or none of the productions are being delayed. So I think the pharma companies had been did a great job during the vaccine development or during this crisis to make sure that we all are getting back to a normal, normal life as possible. So I think they did a good job with it.
Yeah, Dr. Bourla, who spoke at the Touro 50th anniversary dinner a couple of nights ago, also mentioned in support of what you had talked about, that there's now a working group together with Bill Gates of pharma companies that meet to determine how they can work together in ways that perhaps they hadn't in the past to respond to public health issues and to chronic diseases. So perhaps there's been some progress, which sometimes happens even in tragedies. So we're almost at 2:00, so I want to thank everyone and the speakers for participating, Dr. Halpern for moderating, and the audience for joining us. Thanks a lot and have a great day.